see my slide and hear me? If not, just give a shout or let us know. We'll have to address that. With regards to the housekeeping rules, obviously, if you have any question during the presentation, put your hand up or you can type into the chat box. One of my colleagues, Dr. Butch, will be monitoring that. Feel free to ask me questions during the chat, as well as we have question time at the end. There is a link for feedback, which I will remind you at the end as well. Unless you fill that in, you will not get your CPD. You also need to enter the name of your trust. I want you to do that as soon as you can in the next 5-10 minutes, please, so that we will know where to send your CPD certificate. I hope that's all clear now. To this afternoon, basically, as the slide in front of you tells you, we're going to cover various aspects of your CESR supervision and also about CESR itself. And we've got 4 speakers to do that. I'm going to kick off with the CESR overview and tips on how to supervise CESR doctors. I'm Sandra Mowley, consultant ophthalmologist from Wolverhampton. My slide is not moving, so bear with me. Harit, can you do something? It's frozen. Oh, it's coming now. Thank you. Well, CESR stands for Certificate of Eligibility for Specialist Registration.
Modi, your slide is not changed on the screen.
Oh.
You might have to share your desktop and then run the slides through that. Oh, we can see it.
You can see it? Okay. It's a slideshow that's playing up. Now, can you see it?
Yeah.
Okay. Well, to repeat it, Certificate of Eligibility for Specialist Registration, that's the acronym for CESR. And obviously, you'll have lots of questions. What is it? Why are we talking about it, etc., which is what we're going to unravel in the next few minutes. And I'm going to top it up with some tips for you. With regards to what is it? It's basically to become a consultant in the UK, you have to be on the specialist register. And there are 2 routes. One is the certificate of completion of training, which is the normal trainee route that we are all very familiar with. And 2 is the CESR. They both are equal to each other as far as the UK specialist register is concerned. Bit of history, I won't bore you with that. It started in 1996, where only training was taken into account. Then the famous Article 14 route was devised by P. Medbey. It was very brief, where experience and training was taken into account. Subsequently, GMC took over, which is what we have now, and it's an Article 9 of the Order of Council. And we really don't know what holds for future. And the whole thing has come about because of the mismatch between trainee numbers and consultant posts. There are more consultant posts and less number of trainees coming through. Later on. You may wonder, why can't we increase the trainee numbers? But it is not possible according to the Health Education England because of money, the paucity of it. So what we need to look at is how we can locally train doctors to fill consultant posts via the CESR route. And it also acts as an incentive for clinical fellows and SAS post holders if they are committed and motivated. The commitment and motivation are extremely important. You'll know more as the story goes on. Who should be a CESR applicant? Basically, he needs to provide a portfolio of evidence to show that he or she has equivalent training and experience to that of a CCT candidate. Lots of people would have asked or thought about, what about the European doctors? Well, there is an European law, so we have no hold over it. But interestingly, some of our European counterparts do not recognize our CESR. They only recognize our CCT. You might have heard this before. And of course, with Brexit, we still do not know what holds in future for that group of doctors. Interestingly, the minimum eligibility requirement for a CESR applicant is a postgraduate specialist qualification in that particular specialty and or 6 months experience in the specialty. That's the minimum, which is obviously not going to fulfill most of the applications. Why do we need it? Well, the standard is set to match up with the CCT program so that they are suitable for appointment to the NHS consultant. And you got to remember, it is nothing to do with GMC or your Royal College. They help in the process, but the order or the standard is set by the order of Parliament. Okay. And we need it because of patient care being the center of all our attention. And we always need to question, is this the person who is of a similar standard to that of being awarded CCT? And it's not about staying on the specialist register, but it's about getting into the specialist register. Revalidation takes care of the later part, which we are all familiar with. A few nomenclature you need to be aware of. This CESR for specialties, there are about 65 of them.
Excuse me, Dr. Sandramoli.
Yeah?
The
Sorry?
slides are not moving. I don't know whether it's moving on your screen, but we can't see any slides.
It now?
Yes.
Yeah, we can. It's moved now.
Okay.
Yeah, they are moving now.
There are about 65 specialties which is covered by CESR, which is specialty specific, like ophthalmology, A&E, like that, which is available on GMC for you to look at. The other one is non-CCT, it is called, where a subspecialty within the particular field can also be accredited, but the knowledge and skill should be similar to that of an NHS consultant for that area. To give you an example, I can give you an example from ophthalmology. If somebody wants to be only in neuro-ophthalmology, he needs to show the skill and knowledge of neuro-ophthalmology, which is a part of a general specialty, to prove that he is registered for CESR non-CCT. You'll know more as we unravel this. Is the slide moving now?
Yes.
Yeah, okay. There's something called CESR CP, which is a combined program, which, as the slide says, it's a hybrid between specialty training program and whatever that the person has earned by way of competencies from previously non-approved training posts. This exists for some specialties, and it's all available on the GMC if you unravel your respective specialty. And like we have for CCT, academic CCT, we have academic CESR 2, and that is to cover with both academic and research part of that specialty and the clinical side of that particular specialty. So it's a double whammy, like you see in your academic post with CCTs. It often involves getting the relevant postgrad qualification like PhD, etc. It's all about equivalence, as the name, includes the word equivalent. It's not about identical training. So it's not, matching up entirely. And it doesn't matter where the training and experience was obtained, as long as the primary medical qualification is recognized by GMC and evidence has to be provided for that particular skill that was obtained from wherever in the world. And it need not be in a training post. I repeat, it can be on non-training grades. That's why clinical fellows and SAS doctors can all qualify as long as the evidence is provided to prove that they are equivalent to the CCT standard. Any questions? Because in this virtual platform, I don't know how these things are syncing. So if you have any questions, please ask me now.
So Muli, Mr. Sandramoli, we've got, do you want to take questions now? Because there are two hands which are, I don't know whether they are genuine or inadvertent, but there is somebody, Rupan is.
Hi, yeah, just Rupan Banga, one of the ENT consultants from the QE. Mine was really just a general thing. I can't see the chat function, so I just wanted the link to do the feedback at the end, but that wasn't particularly urgent right now.
Okay, we'll put it up in a few minutes then.
I think we can't see the chat function, Mr. Sandramoli. There isn't one coming up.
Is it?
Yeah.
I don't know how you can include it. I don't know because I'm already sharing the screen.
I can see it. It's on the top. It's on the top control panel next to participants icon. Can you see the icon to raise your hand?
Yeah.
Just next to it, there is a box.
Yeah.
It says conversation.
No.
It's not on mine as well.
Even on mine, there is no box there.
Oh, I'm privileged.
Probably, yes.
Okay, so I think the next person, Mohammed Wani, has hand up.
Can I ask a question?
Yeah. Sorry,
Yeah.
just a quick question. Will this session be recorded? Because it might benefit later on to share that recording with the group or maybe some other
I
members
think it
as
is
well.
being recorded. I could see that button is on, recording button.
That's fine. So once this is over, if this could be shared to participants, that will be really helpful at our local levels.
Yeah.
Thank you.
Being recorded.
Okay.
Pratap Makam.
This is Dr. Markham here from New Cross Hospitals, Mr.
Hi.
Sandramoli.
Yeah.
Anesthetists. I mean, a couple of fellows we have got doing their only specialty cardiothoracic fellowship who have come from abroad.
Yeah.
They are interested in going through CESR, but if they want to fulfill the CESR through proper route, as you said, it takes a long time. You mentioned about non-specialty route.
Yeah.
So if they are competent enough in that field, are they eligible now?
Well, if you remember, the non-specialty will be a subgroup within the specialty of cardiothoracic anesthesia.
Yes.
And the knowledge and skills should be that of an NHS consultant. So they still need time to gather that evidence, not necessarily the same, breadth of knowledge is required. So it's only a sub-unit of your specialty. Time taken will be less, but nevertheless, it will still be time spent.
And once they have one more question. Once they have gone through this CESR non-specialty route, are they eligible to apply anywhere in the country, or is it restricted to the hospitals they are getting through?
I think that's a different question. It's not to do with CESR, it's to do with the job opportunities. Not many trusts want you to be super specialist, isn't it? This is basically, we're talking of super specialist.
Yes,
approach.
Absolutely.
And it's not necessarily required in all the hospitals. So that's a separate topic in itself.
Okay, right. Thank you.
Okay, I think Mr. Sandramoli, there are quite a few hands will come. I think, shall we leave it till you finish, or did you want to carry on? There are a few other questions, I think.
I think I will give a break. I will continue with the topic now because we don't want to be completely waylaid into questions. We will have questions at the end of this presentation. I just wanted to know if you guys are on the board because I can't see any of you through my computer. That's why. It's a new experience for me, so bear with me. Right, moving on. For a CESR, both for the supervisor and the candidate, there is loads of guidance on the individual college website and GMC website. And the whole thing is underpinned by the relevant curriculum, which has to be gone in detail. It's available on the net. And all the evidence that you need to cover should be pertaining to the learning outcomes of the curriculum. It's an online application format through which you submit your evidence. You have what's called as structured reports, which will be elaborated in more detail from 4 referees. At the end of the day, it's an e-submission of paper-based evidence, which is collected as a portal submitted for the
Can everybody please mute their microphones because there's a lot of disturbance coming through.
Yeah, thank you. And the whole application submission of evidence is based on the 4 the GMC's medical practice, which you are all very familiar with, but I will reiterate as we go along. Can you see the slide now?
Yeah, we can see.
Yeah. It's
Yeah,
a
yeah.
documentary evidence,
Properly.
which is in the form of a specialty specific guidance. We call it SSG, which covers your CV, evidence of your qualifications or any examinations passed. Lots of details of your employment records are required. Logbooks, consolidation reports, evidence from specific cases are also to be submitted. This is just a snapshot of what it entails. Appraisal portfolios for the last 5 years, work-based assessments, MSF, multi-source feedback 360-degree appraisal, and then evidence of participation in teaching, audit, and governance in your local unit. This is based on GMC's good medical practice, which you are all very familiar with. And this is a slide to just recap on that.
Excuse me, could you make it slideshow bigger, please? It's not in slideshow. Full screen, please. Thank you.
Can you see it now?
I don't think we have tried this before. It's not proving successful. Changing it to, I think the presenter can see it in slideshow, but it's not coming across on the screen.
Yeah.
Harith, can I just tell you, I did a similar talk yesterday to everybody across UK in pathology. And what you need to do is stop sharing, put it onto your slideshow mode on your computer, and then start sharing again, and it will work.
Yeah, okay, we can try that. I think that was tried earlier on, but Mr. Sandramulli, do you want to do that? Just come off it and put it on PowerPoint slideshow and then share it.
Yeah, but if I put PowerPoint, I can't see the,
No, when you put it on PowerPoint, Muli, then on your computer, on the keyboard, you can see the Windows icon. It's between your Control and Alt.
Okay, okay.
You press that and then you will see the Teams, and then you can click on that and share. We're all learning this every day.
I'll give it a go, but I can't see anything at the bottom.
No, on your keyboard, you must be having a Windows icon. It's like 4 boxes together next to the Alt, Control Alt.
Yeah.
So once you've put it onto slideshow mode, click on that.
Okay.
And then you can see your desktop again.
Okay. Yeah, I can.
Yeah, and then you can share.
Okay, I'm with you. Give me a second. No.
I can see your slide.
You can see it as a PowerPoint?
I can see your desktop. So just go to slideshow start and it will start now. I can see as PowerPoint.
Yeah, but not as a slideshow.
It's not a slideshow yet.
Right, I'm not getting it then.
You have to enlarge the window.
Just enlarge it. I can see it clearly now, so you don't need to do slideshow.
Just maximize it.
I think it's best to move on with it anyway.
We can see it anyway. Go back.
Wait, I've lost the whole thing. Just hang on, please, guys. Sorry, I've completely lost. Just hang on. It again. Sorry, it's frustrating. I'm sorry. Can't see my slide now.
Do you want to email it to me and I can try it from on my end?
Yeah.
It might be easier to share your desktop and then just go through the slides through the desktop.
Forward it to Harit now. Send.
Moli, are you sending it to me or you're trying it yourself?
I've sent it. I've sent it.
I haven't got it, so I think you might as well keep trying. I've managed to come. Okay,
Has it come?
Yeah.
Okay. Do you want to share it?
Let me see if we can do what
Anjali suggested.
Yeah, so Harit, just open it on your desktop and click on Start the Slideshow.
Yeah, I have.
Once you're ready, then you can see on your bottom left-hand side on the keyboard, the Windows sign.
Between Control and Alt.
Then you can see Microsoft Teams again. Click on that.
No, I can't see Microsoft Teams even after clicking on that.
Windows.
That's strange. Your whole.
Are you able to see it now?
Yeah.
Yeah.
There, yeah. We can see now.
Which slide, Muli, were we on?
Going.
Yeah, it's okay now.
Keep going. We are on the chart which shows the domain 1, 2, 3, and 4. A bar chart. More. That's it. Yeah. Okay, I'm starting again. The domain 1 is the bulk of the evidence. It covers 75% of the evidence. Domain 2, 20%, governance, etc. And then domains 3 and 4 are roughly about 5%, but you got to pass each domain. In other words, every competency has to be passed, even though the weight of evidence is higher on the domain 1 as compared. Next. Harit, can you move it?
No, it's not moving now.
So it's a different problem now.
Okay.
Yeah.
Got it.
And the whole assessment of the evidence is done against the college curriculum, which, as you all know, is moving on to the generic capability curriculum that is now being, introduced. I think they're hoping to complete across all specialties by late next year. And under each domain, different evidences are required, and it's all based on competence and not just number. And all learning outcomes, as I said, have to be presented uncleared. So you can't just be slackening on one and then concentrating on another. Next slide, please. This word triangulation comes very often in the assessment of a CESR application. So it's important to know that we place different levels of weight of evidence towards various kinds of evidences. For example, if a statement is given by a referee, like a testimonial saying, oh, so-and-so covers all competencies and I know him very well, etc., as a typical testimonial does quite often, then that's a very weak evidence. The strongest evidence is workplace-based assessments, logbooks, exams, and things like that. There are some in-between weak evidences, such as a consultant listing out all the competencies without any WPBA, and saying he or she meets all the requirements. That's considered a weak evidence. But as part of submission, you got to have all the evidences, not just the strong alone. So it is a triangulation of all the evidences that enables us to say, yes, this person is good or not good. Remember, it's not similar to what the CCT candidates do. They have regular ARCP and so on and so forth. They have a very structured way of assessments. We do not have that. So as a result, the application is very much based on weight of evidence and how the triangulation of evidence points us in the direction of, yes, this competency is met or otherwise. Next slide, please.
Hi, is Manik there?
So the primary evidence relating to mainly domain 1 is things like exams, workplace-based assessments, logbooks, cumulative data sheets, audits, research, etc. As you can see, casebooks. Next slide, please. Logbooks are very, and often all the colleges have their own, and it's very important to show cumulative records so that the assessor can eyeball it and quickly come to a conclusion as to how well it is covered. Often, in fact, as part of the procedure, GMC will ask one of the supervisors to validate. For those of you who might have seen this or signed off multiple forms to validate each sheet that is submitted, that's historical now. It's done by one assessor or one supervisor for each unit. So if I'm working in Wolverhampton and I'm submitting my training based on evidence collected from Wolverhampton, I have to show or name one supervisor from Wolverhampton to sign off for everything, usually the college tutor. And likewise, if I moved on to say Watford or somewhere else, then that also needs to be, covered by one supervisor for each unit. Very important that it's very important that there's no patient identifiable information in that logbook because it is to do with information governance. And things like just copies of data just to show that I've done this is not good enough. You've got to give much more details as you do in a logbook. Just being scrubbed, just being in the theater is not good enough. You have to be scrubbed as part of the procedure. So you have to show how involved were you in the procedure. Next slide, please. There are lots of secondary evidence and support, which I'll elaborate in a few minutes, of 4 referees is important, testimonials, MSF. So you can see they're all weaker evidence, but they are nevertheless required to make a case for your evidence to be counted. Next slide, please. This term is often used by all the assessors. What it means is if you have done a particular procedure, say 15 years ago, thousands of them, but you've never done anything in the last 5 years, then usually it stacks up against you. You need to show that that particular skill or competency is current and maintained in your training and experience. So it should be usually the last 5 years because most of the higher surgical or higher medical training covers 5 years. That's where the magical number comes into it. Without that, you can't say that you're up to date, which makes sense if you think about it. So current and maintained skills are extremely vital. Next slide, please. And as an assessor, we look for it. I did mention about structured reports a few times before. Basically, it's a referee's report who has got a direct knowledge of the applicant's work and training, usually a college tutor or a supervisor who has worked closely with that candidate. And it's purely based on direct observation, not on hearsay. And it should be obviously carrying more weight if you do it within the last 5 years, people whom you have worked with. And it is the applicant's prerogative to name those 4 referees. One referee has to be a medical or clinical director because they know more about domains 3 and 4 aspects of you than your direct supervisor. And 4 such reports are required. You can give more, but 4 is minimum requirement, of which 1 has to be somebody in the management side, but clinical. Next slide, please. These are the things we normally look for. Basically, when you're assessed, we often expect that you've demonstrated the application of knowledge and experience to your practice. You've shown your ability to work within your competencies, keeping up to date with all the things that are necessary. You also have to be able to demonstrate that you're a good teacher trainer, because NHS, as you know, involves lots of informal training and sometimes very formal as well. And you should be able to demonstrate that you're able to manage the patient both within your own remit as well as beyond you. And record keeping is also important. And you got to be able to demonstrate that by showing letters of communication, etc. Next slide, please. And the evidence is usually in the form of structured reports, testimonials, multi-source feedback, appraisal, apart from all the logbook and the other things that we have covered earlier, CPD activity, audit, etc., because they all show that your skill, knowledge, and performance are current and up to date as well. It also shows the breadth of your knowledge, which is quite important to show in your application. And as a supervisor, we need to ensure that those things are imparted to the candidate. Next slide, please. Safety and quality is the theme of domain 2, and it very much covers all the mandatory activities or training that we do, audit activities, clinical governance meetings, not just presenting things, but you also should demonstrate that you've been attending regularly or somebody should vouch for it, which often happens with the structured report. And anything you've done extraordinarily, like reporting a critical incident and following it through, or or involved in a root cause analysis, for example, testimonials, MSF, all these things cover the evidence that you need to demonstrate for domain 2 related stuff. Next slide, please. And carrying on from there, again, safety and quality, you've got to show all these things to show that you have covered the necessary competencies. It could be in the form of you presenting things, or it could be in the form of you having attended a course even. Next slide, please. These are again repetitive stuff, which again overlaps onto domain 3. Often your clinical director can cover these aspects as well. Next slide, please. And evidence 4, which is more important for a clinical or a managerial person to do it, but it should not be a manager, it should be a clinical manager. It should not be a group manager, for example. And data protection is very important. Say, for example, if you do a logbook submission without covering the details of the patient, then GMC will often tell you to attend a data protection course and show evidence that you are actually up to speed with it, because you made a goof up when you submitted in the first instance. Responding to complaints is another skill, which, as you know, everybody should know, and it is often expected to be covered as part of your specialty specific guidance submission under domain 4. Next slide, please. This is a very busy slide. It down in a minute. When a candidate submits the application, it's just an overview of what happens when an application is submitted. Next slide, please. The initial assessment is done by the GMC. They go through it and they basically contact this referee that you have named as an applicant for structured reports. They contact the verifier to verify the evidence that was submitted against various categories of your competencies. And this they accumulate within 14 days in terms of dispatching it. They don't expect you to write a structured report in 14 days and submit it back to GMC, which will be covered in the next slide. Next slide, please. And what GMC does is they create a checklist to ensure that you've submitted everything, not necessarily commenting on the quality, but evidence has been submitted. For example, if you have not submitted any audit at all, the GMC will flag it up in their checklist saying there's no audit. Do you want to submit an audit? Maybe you've overlooked it. And they give you 60 days to send back an audit or something like the example I gave you just now to ensure that you are happy for the next process to start, which is sending it to the college. Next slide, please. So they would have, by the time they send it to the college, all the structured report would have been received, all the verifiers report would have been received, and you can see it says approved evaluation sent to college. And underneath at the bottom, it says 3 months deadline, which is legal because once the GMC sends it to the college, there are only 3 months before a verdict can be pronounced to the candidate, which you can appeal if it is not done in good time, which is 3 months. Okay. Next slide, please. This is just an overview of what happens in, say, Royal College of Ophthalmologists in my domain. So I know I'm more familiar with this. It varies from college to college, but essentially the bundle that is submitted electronically is given to 2 assessors. One of them is the lead assessor, so he takes the full responsibility, but both the assessors go through the individual evidence and they complete a standard evaluation form to show what has been done to a good standard and what has not been done at all or what has been done to a substandard. This is a quality review. So it is done extensively by the assessors. In ophthalmology, we have a discussion on telephone to know whether this application has been completely covering everything so that we don't miss anything that has been submitted. It's a lot of hard work that goes into it. So we painstakingly go through everything and ensure we've covered and commented on all the evidence submitted. And then we do a final report, which includes whether the candidate is good enough or not adequately submitted. And if it is inadequate, we have to give recommendations as to what is it that is to be addressed. Okay, next slide, please. So if successful in the first go, the GMC will say, yeah, we are very happy with your standard. You've reached the standard and we are going to put you in the specialist register and you've been awarded the certificate of CESR, which then is the beginning of your next saga, namely making yourself more marketable with fellowship, etc., to rub shoulders with the CCT candidates to get into a consultant post. Next slide, please. Of course, if it is not successful, a GMC will send you a letter confirming what is it that you are not adequately covering, and they give you the recommendations, and they will then give you time to appeal to that. With that, it finishes. But the feedback is very useful for the applicant. If a couple of areas are missing, the feedback will elaborate on that so that you can actually appeal again, or what I call as review it. You can send a review application within a year, which is the next slide, please. So if you are only to cover 1 or 2 areas, which you think, which you've been thought out to be not adequately covered, then within a year of that decision letter, you can provide further evidence just for those areas where you have failed, where you have not satisfied the assessors. You don't have to submit the whole thing again.
Okay, this is important.
At any stage, you can appeal, and that is done entirely independent of the GMC, and it can be done on a written or an oral format. If there are too many recommendations and you can't achieve them within a year, then unfortunately the candidate may have to be forced to give up and try it all over again when they are ready. Next slide, please. This is just a insight into where do most applicants fail. It's often on very obvious things which are already there in the specialty specific requirements. There are no surprises. It's often due to candidates not applying themselves with good attention to the details. There are lots of guidance documents and they need to read them, understand them, and follow them. It's a lot of documents, hence there is a very high chance of missing out on things, which is where as a supervisor you can help them, and I'll tell you as we go along. Next slide, please. Of course, money is always important. This is just the latest one from April 2020. The initial application costs a fortune. Review application costs lesser of a fortune. And if somebody wants a written appeal, again, it's a walloping sum. Oral appeal is a lot more tedious process, so it's a lot more costlier. Next slide, please. I'm sure you're all interested as to how well it is done and across the patch, what happens. This is just an annual report from GMC showing the number of applications received. As you can see, it is on the up, not surprisingly. Next slide, please. This is just a slide to show that there are more surgical and physician applications and lots of other areas are there. And if you can see on the bottom left, it's 10%. That's obstetrics and gynecology. That's number. And there's a 9 o'clock position, which is anesthetics. So this is just a snapshot view of what happens in various fields. Next one, please. This is the success rate of all applications. You can see it's roughly hovering around 45 to 55 or 57% pass rate. To break it down further, next slide, please. You can see the radiology has a very high success rate of 83, and some of the other specialties like urology has quite a low percentage success, like 36%.
It's interesting.
So you can see generally hovering around the 50s pass rate. But there's a range like any other aspects in life. Next slide, please. And this is just a rough view of how many were successful on review application. You can see lots of them are successful in reviews because they have to address what is missing in the primary application, which is often very small. You can see there's a high pass rate. The lighter blue is the granted one and the darker blue is the refused ones. Next slide, please. I'll cover the tips as well before we go into the question section. One of the key things as a supervisor, if you're going to have CESR fellows or you want to inculcate the habit of promoting CESR, I think you need to be very realistic as to it's not just you who is involved in that, it's your entire team. Do you have the infrastructure is something you need to question. And as a team, can you do it? And do you really need local candidates to be groomed for posts within your unit? It's a selfish motive, which often works better. The next onus is on identifying an appropriate candidate. Appropriate candidate should have all the good attributes of motivation and dedication towards it. Trust me, it's a time-consuming process. It's not for everybody. It should not be forced. It should be very much down to the individual, and it is our job as supervisor to encourage them accordingly. Yes, everybody can do it, but at the same time, not everybody can do it. That's the truth of it. Prior experience with evidence is often very helpful, and attributes which are relevant to domains 2 and 4, say, for example, if you have an SAS doctor who is working with you and you think they have lots of good attributes of domains 2 and 4, but not so much on 1, then you could talk to them and motivate them and check it out whether they are keen and committed, and then enroll them in the process. So there's a lot of groundwork to be done before you start. Don't take it as, okay, I've attended this course, I'm going to start one tomorrow. Please don't. I would like you to, but I would like you to be realistic as well. Next slide, please. And once you are in it, then you need to set them up on short and long-term plans because it is a long process. Often take 3-4 years depending on the candidate's level of commencement. And definitely look at 6-monthly reviews. Ensure all the domains are covered. And you need to constantly ask your colleagues also to help out. You can't do it all by yourself. And remember, some of the areas like TNO, for example, have requirements to have secondment outside their own hospital if that particular aspect is not provided, like trauma. They expect a certain amount of posting outside. Transplant medicine is another one, in nephrology, for example. So these are areas which you need to be aware of before you even take on a supervision role for a trainee. It's very important to ensure that all is provided and you're able to give them the right experience. Next slide, please. The curriculum as well as the SSG always insist on test of knowledge, which is usually the exam. And it's often helpful to know whether the person has already covered the exam part of it. And that is often a test of motivation, if you ask me. And coverage of core curriculum, there is no way you can avoid that. Ensure that all aspects of clinical governance is covered. Their skills are current and maintained and not beyond 5 years. And eventually when they present, it is extremely vital to ensure that the presentation of the bundle is appropriately anonymized and assessor friendly. If you annoy the assessor, the chances of you not ticking all the boxes are going to be higher. It's an obvious logical thing to think of. It works very well amongst the candidates if they have buddies, which I think John Mohammed will cover as we talk about in his experience or of his journey. Earlier, all areas have to be passed. All areas have to be absolutely cleared. There's no corners cut. You can't focus on one and ignore the other. I think I've come to the end of it. Just in case, any other slide next, please. Our trust is very good at this, and I would inculcate this habit of, we have an educational supervisor who's named. The educational supervisor has what is called as an educational agreement, which is what is expected of the candidate to be covered in the next 6 months, the so-called bite-sized target. And you don't have to wait for 6 months to be assessed. It can be interim assessment also. And at least an annual ARCP will be very helpful. And if you have a trust which is promoting it, like Wolverhampton, then that's great because that carries a lot of weight and it's a useful time to feedback to the candidate. Next slide, please. As I said, test of knowledge is very essential for lots of colleges. Ophthalmology is one of them, definitely. You have to be familiar with college guidelines of your specialty, which is often very elaborately detailed in the SSG, specialty specific guidance. And there's no harm in making the test of knowledge as a prerequisite before you enroll a person as a CESR fellow. I certainly would encourage that. And if the candidate is highly motivated and has got all the boxes ticked, that's the right candidate for you to choose and encourage them to achieve this difficult task. Next slide, please. We often have a few specialties where the research experience is given a lot of importance. For example, in ophthalmology, everybody is expected to show good clinical practice coverage by way of having attended an online course. We are encouraging all the candidates to get into portfolio studies or ethically approved projects if possible. Specialties like surgery have case series, presentations, publications encouraged and mandatory. So we need to be able to provide all that. It's not just the clinical side alone. And they have to be actively involved in various posters and presentations. Next slide, please. As I said earlier, the triangulation of evidence is very important. So I'm just reiterating what we expect. Plenty of workplace-based assessments, testimonials, courses, CPD, lots of case records to show your breadth of knowledge, lots of letters to show that you can actually manage with communication as well as relevant referrals outside and how you react to other comments, etc. And it's very important to get reports from non-medical individuals like medical secretaries, technicians, and auxiliary health personnel. So it's not just doctors and medically qualified people alone. That's why the MSF has to be recent, at least within the last 12 months, by the time you encourage your candidate to submit their evidence. Next slide, please. Yeah, don't forget SSG. That's one thing which you need to definitely be familiar with. And once you know your specialty, you'll be able to follow the other specialties as well, if you are to guide them in various other specialties. And GMC has a very specific way of writing CV, so that needs to be adhered to, often missed, and often comes back to you as a recommendation. I think I've come to the end of it. I'm happy to take questions now.
Hi, I've put my hand up previously. I just wanted to ask, because I work in a very small department in dermatology where there's only one consultant, and I myself am an associate specialist level. I would like to be involved in a bit more. I'm sort of working as a locum consultant. Will locum consultants and associate specialist level doctors be appropriate to be one of the referees?
Well, in your department, it looks like it's absolutely necessary, but I don't know how the person will get 4 referees in your case.
That's the event, because there's about 5 of us, but there's only one consultant, and the rest of the 4 doctors are associate specialist level. But we do work closely with other departments like oncology, histopathology, and also plastic surgery, because we can't cope with the level of work ourselves. Would it be appropriate to use out of specialty doctors at times?
Yeah, absolutely. Absolutely. The important thing is they should have a direct knowledge of directly observing that candidate at work.
Right. Okay. Because as I say, we work very unusually, skin cancer being the primary focus of work. So we work very closely with oncology and plastic surgery because of that.
Yeah. I think it's appropriate in that case, as long as it is nicely, laying out all the details relevant to the competencies that are to be, demonstrated in your particular field.
Okay. Thank you very much.
Dr. Molly.
I've got a doctor. Shall I just call out the names, because we got loads of questions. Dr. Amol Sagdio.
Yeah. Hi, Dr. Molly. Thank you for a nice detailed talk. I have done CESR in GIM myself recently.
Yeah.
I have been told by a few candidates who have applied that GMC is sending them a letter saying that because of the COVID, we are not able to process any applications at the moment. Do you know about what sort of duration we are looking at when they are holding off the assessments?
Well, it was very acute, in fact, around the months of April till June, but it has now become more easier to engage people. In fact, I assessed somebody 8 weeks ago,
Right.
So it depends on the specialty, I think. For ophthalmology, I can certainly speak. As I said, I assessed somebody 8 weeks ago in August.
I think I heard it from the radiology and general medicine applicant.
It must be because they were struggling to get an assessor. It's more to do with that, but it should not be the case now. And talking of COVID, they've also extended. I kept on saying 5 years. Actually, they've made it 6 years now, because they know a lot of people could not get their relevant information in the past, last 8-9 months. Things have gone really up. So they are extending it to 6 years to ensure that people are not, losing out on their evidence collected in, say, 2014, if they are to submit their applications now.
Okay. Somebody called Bash. If you have just had your questions already answered, can you please put your hand down? Because otherwise I'll come back to you. I won't remember that I've already done so once. Mr. Bash.
Can you hear me?
Yeah.
I just wanted to ask Dr. Mooley, thanks very much. That was really helpful. You mentioned Wolverhampton encouraging the ARCP process for the CESR applicants. Is that the like the regular ARCP that all the other, regular trainees are on, or is this a kind of your own ARCP? Because I imagine it'd be difficult to get them on the regular ARCP.
It's our own, and Dr. Butch will be covering that in his talk.
Okay.
Yeah.
Can I ask another quick one? Just you mentioned like plenty of work-based place assessments.
Yeah.
Do you have to strictly adhere to the number that they say in the trainees, or is it a rough equivalence?
It's a rough equivalent, but generally, as a rule of thumb, anything common, I would insist on at least 2 WPBAs. And it's important while talking about it that it should not be a bunched up WPBA, meaning, say, cataract surgery and you've got 2 signed off on the same day. I would look down upon it. I would rather want you to show 2 WPBAs from 2 different time periods, for example. It's called bunching up. Don't bunch up. Please tell your candidates not to bunch up their evidence.
Thanks so much.
Mr. David Phillips.
Oh, thank you. I'm supporting a candidate for this, but he's been told that he has to produce publications. How important is it that he is the first name on the publication, or can he be on anywhere on the list of patients of the authors? Thank you.
Yeah. I think certain fields are very strict about it, like surgery and orthopedics, for example, and it's not negotiable. They have to be first authors, and they insist on that. But in ophthalmology, for example, we don't even have publications as a mandatory requirement. So it's very much down to the SSG again. That's where the knowledge of SSG for a relevant specialty is important. You can't paint everybody with the same brush.
Okay, that's very helpful. Thank you.
Thank you.
Miss Dr. Shokri. It's Adele Shokri.
Thank you. Yeah, I'm Dr. Shukri, a SAS tutor at Russell's Hall Hospital in Dudley. Thank you very much for your talk, very informative. But I just have a quick question. I noticed from the graph that the surgical specialties like trauma and orthopedic and radiology have a very high acceptance and success compared to dermatology, like 20%. It seems it's a difficulty in gathering the evidence, probably. Yeah. And my question is, if you look at the medical specialty curriculum required, it's always a CMT curriculum for 2 years and the specialty curriculum. Yeah. A lot of our SAS doctors will have the specialty curriculum completely fulfilled because they have been working in this specialty for many years. Yeah. But the CMT, for example, if we take dermatology, they haven't done ascitic tap or central venous line or DC cardioversion. Do they have to fulfill all the CT skills and procedures?
Well, it very much depends on what's stated in the curriculum. If the curriculum is asking you to take the CMT areas, then I'm afraid it needs to be demonstrated.
Yeah, the curriculum in all medical specialties specify that we have to have the CMT fulfilled, plus then the specialty.
I don't think they will insist on CMT being fulfilled in the CESR, but they will insist on the competencies that are covered by CMT to have been presented as evidence. If you see
Sorry, this competence requires the procedures, isn't it?
Yes, and I'm afraid if that needs to be part of your curriculum, then you need to be making time to do it and getting signed off.
All right, because the difficulty here that we are talking about, like 7, 8 different specialties, which the person have not done for over 15 years, for example.
I'll give you an example. In ophthalmology, we do cataract surgery and using the microscope. Okay. Mm-hmm. But in the first 2 years, which we don't have a CMT, ours is a 7-year run-through program. In the first 2 years, you're obviously going to attend microsurgical skills course and get signed off for how you can use the microscope.
Yeah.
That's a basic requirement. But when they submit their evidence, they still have to show a workplace-based assessment relevant to how they can use the microscope competently.
Yeah, no, I understand, but I'm just showing the difficulty in medicine is different. Yeah.
Yeah,
Thank
it
you.
is. It is. I'm just giving you an example based on my own, work sphere. And the bottom line is, if it is there in the curriculum, then I'm afraid it needs to be shown. And there are ways to do it. Honestly, the 20% you said have passed, that means they've shown it.
Yeah, they must have. Yeah.
I can quickly answer that question. I think the answer very quickly is yes, you do need to show the competency, because I've gone through lots of these medical specialties. They all need CMT curriculum. There is no way around it. That's the first question they ask me as an assessor. So that's the answer.
Right. Thank you.
Andrew,
just to answer that question, if you have the MRCP, that would be a form of competency.
Well, I think even if you have MRCP, you still need procedural competencies. The MRCP will obviate the need for many other competencies. You're absolutely right, but the procedural competencies are not assessed in MRCP.
Yeah.
Thanks.
Mr. Garnham?
So just a couple of comments, really. One is around the need for publication, and surgery have been very inconsistent with this, and this is one of the reasons that the GMC is intent on removing this from all specialty curricula, that they wish us to have no requirement to publish, which as a TPD, that's quite important for me, because I cannot guarantee the vagaries of journal editorship. So it's not something I can produce as part of a training scheme. So that I suspect is going to be removed from all specialty curricula. I've been specifically involved with vascular, and it's going out as of next year's curricula. And just to comment on the WBAs, I think the easiest way to demonstrate competency is to use the work-based assessments in whatever specialty you happen to be in to demonstrate equivalence, really, because actually what a CESR is an equivalence in terms of specialist registration.
Thank you. Thank you.
Thank you, Andy. Viswanathan.
Yes. Hi, I'm Viswanathan Chandramula. I'm one of the ophthalmologists from the Shrewsbury Hospital, consultant ophthalmologist.
Yeah.
I have one particular doubt. In your presentation, you said the candidates can use last 5 years of experience, whichever part of the world it can be.
Yeah.
Then who is going to approve the quality of the work? For example, if somebody works there in ophthalmology for 4 years, last 4 years, and they come here for the 5th year, and submitting the application for CESR, and they ask us to sign the previous 4 years of ophthalmology experience, or do you ask for the signed by the consultants from the different country? Do you still accept that as a standard?
So the verifier is named by you, actually, relevant to the area where you have worked, and they will be contacted. And it's often difficult, as you can see, the logistic difficulty is a nightmare because they are not familiar with the UK system.
Yes.
So hence, I always feel that last 2 years, if the candidate works here and uses all the relevant information from the past experience, with top up in the last 2 years, they have more high likelihood of getting through.
Okay. Or the best thing you would say that
it's using your experience and not wasting it, but at the same time, it is a lot more logistically simpler if you have last 2 years in this country.
Okay. Thank you very much.
Mr. Sandramuli, shall we just go for one last question? There will be time at the very end if somebody wants to carry on. So the last one, I have to say, Dr. Ansari, Ziauddin Ansari.
Yeah, hi, I'm Dr. Ziauddin Ansari, one of the respiratory consultant working at City Hospital. Thank you for your presentation. I just have 2 questions. One, if somebody wants to do if they want to apply respiratory medicine along with general internal medicine, can they apply both at the same time?
Yeah, there's only one format, and you need to check with the specialty listing in GMC. There are 65 specialties, so you may have to consult that. And if in doubt, you can always ask GMC directly.
Yeah, okay. And if somebody new to this country from overseas who have enough experience in respiratory medicine, postgraduate degree and everything, and if they join here as a specialty doctor, do they need to have any like training job in this country, or that specialty doctor post for 2 years itself is enough?
As I said, it need not be a training post at all throughout.
Yeah, it used to be like 6 months of training job before.
No, there's no need. As long as you have a postgrad qualification and experience of working in that specialty for 6 months, your minimum criteria is fulfilled, but you don't have to be in a training post at all.
Okay, thank you very much. Yeah.
Thank you. Thank you. So thanks for your patience. You've been very good actually. And the next aspect is more practical because this is from Dr. Jan Mohammed, who is our advanced clinical fellow in nephrology. And he's going to tell us about his expectations from a CESR educational supervisor from a physician perspective. Jan is very, very active as a CESR applicant, and he's been very helpful to all other colleagues. He's formed peer group and everything in the trust. He's one of our shining beacons, actually. And I think it'll be very, very enlightening to hear from him about his experience from his journey. Over to Jan. Thank you, Jan.
As long as I'm relieved from my duty of changing slides.
Well, his computer is better equipped than mine.
I can't take the smile that is plastered on my face after such nice words from Mr. Sandramouli. Thank you, sir.
You're welcome. You deserve it.
Thank you. So my name is Dr. Jan Mohammed. I'm an advanced clinical fellow in renal medicine, and I'm looking at submitting my CESR application, hopefully, fingers crossed, in the next 1 or 2 months. And I will give a short talk on my expectations of a CESR supervisor in a medical specialty. So I will just share my screen. Please let me know if you can see my slides. Can everybody see this? Can everybody see this?
I can see it. Yeah.
Yes.
Yeah.
Right.
Go on.
Okay.
Yes.
Okay. So just to so Mr. Sandramouli has explained to us in detail what the CESR process is about. But for a CESR candidate, it is basically the whole CESR process is an out of program in itself. So every CESR doctor or every CESR candidate has embarked on a journey to get his or her name onto the specialist register through this process. The main challenge for this process, if you compare it to the normal training that is offered by the deanery, is that there are no formal academic checks. Okay, so the whole CESR process is a self-driven training whereby the CESR candidate drives his or her own training towards. Are you on hands-free? Sorry, can anybody who's not talking mute their mics, please?
Regarding tomorrow's visit.
I think the problem is the person who's talking cannot hear you.
Should I carry on? I'll just crack on. Okay. So there are no formal academic checks in this process. So basically, the whole the whole onus of running the CESR process lies on the shoulders of the CESR candidate and to a certain extent the CESR candidate's supervisor, be it an educational supervisor or the clinical supervisor. And it's very important that the appropriate supervisor is therefore has certain qualities or certain skills that would help guide the CESR candidate towards his or her ultimate goal. The CESR procedure, as you have been told, is a set of guidelines that are set by the GMC or the concerned Royal College. And these guidelines or these criteria have been refined, and recently it's become more easier to undergo the CESR process. So many years back, it was known as Article 14. And when I remember that when I was new in this country, at the first trust I was working at, I was told that Article 14 is an extremely difficult procedure and you should not even think about it. But subsequently, the GMC and the Royal College of Physicians have refined the criteria, the guidelines, and have made it more user-friendly. without compromising the quality of medical practice that a consultant would have should they attain their specialist registration through the CESR process. So as I mentioned, the onus of going down the CESR pathway lies squarely on the shoulders of the CESR candidate. But there is a need for supervision. And therefore, the CESR education supervisor bears a lot of responsibility as well in guiding the CESR trainee or the CESR candidate towards getting their specialist registration. The process of supervision is not very different from that to a regular trainee. However, may I dare to say that for a CESR trainee or a CESR candidate, the process is even more robust and we have to go the extra mile because we are not part of a formal academic training program. And therefore, the CESR supervisor, his main job is to guide the trainee, guide the CESR candidate to make sure that throughout the CESR career pathway, the candidate is on the right track. Because this training is self-driven, sometimes the clinical fellows or the CESR candidates lose touch with their ultimate goal, and sometimes we just continue to work without gathering any evidence, and we realize after many months have elapsed or many years have elapsed that our ultimate goal, that was specialist registration, has been delayed significantly because we've lost touch. And therefore, the CESR supervisor is there to guide the CESR trainee. And I have grouped the roles of the CESR supervisor into two broad categories. The first role is to make sure that all the necessary and appropriate evidence is gathered according to the GMC and the specialty specific guidelines. So this is very important. The CESR supervisor meets with the CESR candidate on a regular basis and makes sure that whatever the CESR candidate does, in as far as his work is concerned, his or her work is concerned, that appropriate evidence is collected. So if there are clinics that the CESR candidate runs or is part of, then a clinic logbook or workplace-based assessments in the clinic should happen. Feedback from clinic staff is part of the 360-degree feedback. This is just an example. So all appropriate evidence should be collected, and the CESR supervisor should ensure that the CESR candidate is on track in as far as this is concerned. And the second and most important role is to ensure that timescales are met. I just mentioned that because this is a self-driven training, sometimes CESR candidates lose touch and they go off track, and we continue to work without recording or without collecting robust evidence surrounding our work. So this is very important. When we have somebody who is there on the, breathing down the back of our necks, trying to get timescales, trying to get us to meet timescales and meet deadlines, that makes the whole process of the CESR application very, very much smoother. Certain important qualities that a CESR supervisor should have. So one of them, the first and foremost and the most important quality, is that the CESR supervisor should be aware of the CESR process or should be trained in the CESR process. Currently, the GMC and the Royal College of Physicians are offering seminars or workshops on the CESR process and educating NHS consultants. So if a CESR candidate has an education supervisor who is CESR friendly or who is aware of the whole CESR process, then that makes the whole process of supervision very smooth and efficient. I remember when I first decided to join, to go down the CESR pathway, I spoke to some of the consultants and they turned around and said, "What's CESR? Is that Article 14 that you're referring to?" So this awareness is very important. And I think Mr. Sandamouli did a very good job in such a short period of time. He actually went through the important aspects of the CESR application. So that's first and foremost. Secondly, I find it important that the CESR supervisor should be of the same specialty as the CESR candidate. So within medicine, for example, we have many subspecialties. So general CESR guidelines are similar across the board with internal medicine, but there are some vital differences between some subspecialties. So for example, specialties like renal medicine and gastroenterology have a lot of procedures in them as compared to specialties like endocrine medicine and diabetes. So if the CESR supervisor is trained within that specific is a consultant within that specific specialty, that's an added advantage. The second most important thing is time. The CESR supervisor needs to have or needs to dedicate some time or appropriate amount of time to that particular CESR candidate. Remember, this CESR candidate is not in a formal training program. So sometimes you may need to, act as a supervisor, act as the TPD, or at the level of at the level of the deanery, just to try and dedicate more time to this CESR candidate to advise. A lot of challenges come up during evidence collection, during this out of program training, as I like to call it, and it's important that we have enough time and dedication to try and move around these challenges, these hurdles, in order to attain the ultimate goal. Again, it's very important that the education supervisor is well connected and communicates with colleagues across his or her region. Why? Because sometimes it is that you may come across a situation where the CESR candidate cannot tick off certain specialty specific competency within that department or directorate, and may have to go outside of their directorate or outside of the trust for that matter in order for him or her to get that competency signed off. So if the CESR education supervisor is well connected to the management of the hospital or to the directorate or higher authority within the directorate and to other trusts as well, then it becomes very easy for him or her to organize this competency to be signed off. It's also important for the CESR supervisor to be a good listener, because sometimes, and I tell you this from my experience, sometimes the CESR process becomes very frustrating. A trainee which is under the deanery tends to attend regular training days. The CESR candidate cannot do that or does not have that facility to attend those training days. We have to sometimes spend money from our own pocket to attend CPD sessions or extra conferences or go out of our way to keep up with our CPD. Some trusts, like the Royal Wolverhampton Trust, has a certain budget for clinical fellows, which is dedicated to CPD and to extra learning, which is excellent. Not all trusts have that facility. So it's important that the CESR education supervisor is a good listener and a problem solver, and basically guides the CESR candidate through the whole process. So these were the important qualities that I wanted to touch on that I expect my education supervisor to have. So I'll briefly talk about secondment or an attachment, and I'll give you my experience. So in renal medicine, as part of the renal medicine curriculum, it is very important for me to sign off competencies surrounding transplant medicine. And because at the Royal Wolverhampton Trust, we do not have we do not do transplants and take care of immediate post-transplant, immediate post-op care, I had to look for avenue from where I can get that competency signed off. And then we managed to communicate with other trusts, and the whole process was set out, and I managed to have a clinical attachment done at the Queen Elizabeth Hospital in Birmingham, and I got that competency signed off. So many a times we may come across a certain skill or a certain competency that is not available within our directorate or our trust, and it's very important that we communicate with other trusts or other directorates to get that particular competency signed off, because it is an essential part of the curriculum. And as Mr. Sandramuli said, if that does not happen, then it is unlikely that the CESR application will be successful. The challenge is to get a secondment for a CESR candidate are basically trying to account for time spent outside the trust. Rota gaps. How will that particular rota gap be fulfilled? So the education supervisor will have to liaise with the clinical director and with the manager of the department to be able to see how to manage the rota or the absence of the CESR candidate during the time spent at the other directorate or other trust. Another issue is funding. Who is going to pay the candidate's salary? So again, this also needs to be taken into account. So these three issues are very important issues. They are challenges, but there can be, there is a solution. And it all depends on communication and the relationship between the education supervisor, the clinical director, and the trust authorities as well. Regarding evidence collection, so the role of the education supervisor when it comes to evidence collection is very important, and it basically is to advise and to facilitate the collection of the required evidence which is as per the needs of the particular specialty. So the specialty specific guidance, the SSG, again is very important, and the specialty curriculum which can be found on the JRC PTB website is very important. All the evidence needs to mirror the curriculum and the SSG, and it needs to be triangulated. So that's important, and the supervisor plays an important role. Now, for medical specialties, logbooks are important, and I'm sure for surgical specialties as well. So as I said, procedures in medical specialties are very variable. So in renal medicine, in gastro, in respiratory medicine, having separate logbooks for procedures are very important. And when I did my first ARCP, I was advised that it's important when it comes to procedures that there should be at least one sign-off per procedure per year. So for example, if I've been signed off to insert tunneled dialysis catheters, then at least every year I should do a DOPS and keep my competency up to the mark and be signed off. So that's very important. Same goes for endoscopies, same goes for bronchoscopies and any other medical procedures. When you talk about logbooks for clinics, it's very important that that particular logbook reflects the appropriate competencies that are present in the curriculum. So for example, again, I'll give you my example. When I do a renal clinic, in my logbook, I have a section which says focus on management, and I look at, for example, managing renal bone disease or renal anemia. These are curriculum, these are competencies that are specified in the curriculum for renal medicine. So for gastro, for endocrine, for respiratory medicine, for geriatrics, etc., these any specific competencies should come out bold and clear in the clinic logbook. So when the CESR assessor is looking at the clinic logbook, he or she gets a very good idea of what kind of patients were seen in the clinic, how many patients were seen, and what were the particular competencies that were assessed in the clinic. And then we have the ARCP. So at the Royal Wolverhampton Trust, we started the ARCP process, and we call it the Annual Review of CESR Progression, ARCP. And this has started over the last 2 years, and it has been extremely helpful. I cannot overemphasize how helpful this has been, because in the ARCP, we CESR candidates are critically evaluated, and it's better to face criticism during an ARCP process than to face criticism by your CESR assessor when you've already paid £1,600. So this is extremely important. And as an education supervisor at your trust, you can sort of facilitate the whole process of ARCP and help your CESR candidate, critically assess his or her evidence collection and the whole CESR application, the whole application, as a bundle, and then advise them accordingly. So that's the role of a supervisor in as far as evidence collection is concerned. We talked about a CESR buddy. So again, at our trust, we have started a CESR peer group. The whole idea of having a CESR peer group was to come into contact with other doctors who have the same goal as us, that is gaining specialist registration through CESR. And forming this group and running this group has been a phenomenal experience. We talk about the challenges that we all face in our specialties and how to come across, how to face those challenges, how to solve these problems. We organize CPD sessions that are helpful to all of us. So for example, we organized a session on e-portfolio and evidence collection. We organized a session on logbooks. We had consultants who became specialists through the CESR process come to us in the CESR peer group meetings and talk to us about their experiences. We have had 2 sessions by the GMC on the whole CESR process itself, tailor-made for our CESR candidates. So this CESR peer group has been excellent. We have challenges, but we also motivate each other. And therefore this self-driven training then becomes a more sort of a formal training within the CESR peer group. And we try to buddy up with a trainee within our specialty, if not then within the same discipline. So I do not have any other colleague who wants to do CESR in renal medicine, but there are colleagues who want to do CESR in gastro or endocrine. And therefore we sort of meet up and discuss during the CESR peer groups, because GIM, almost the basic criteria, the basic guidelines for CESR are similar. And therefore the basic challenges are also similar. So we meet up, we discuss our challenges, we discuss our problems, we learn from each other's experiences, and we move ahead. So just in conclusion, CESR supervision is a relatively new role. It requires a good amount of knowledge of the CESR process and the respective specialty curriculum in order for the whole process of supervision to go smoothly, both for the supervisor as well as the CESR candidate. We mentioned certain qualities of the education supervisor, and these are very important skills that the education supervisor should have in order for the CESR supervision to be efficient. And patience. So for both the CESR candidate as well as the supervisor, patience is key, because the process is cumbersome, but it is doable. And we really appreciate the efforts done by the GMC and the Royal College of Physicians to make these guidelines more clearer for us in order for us to become specialists in our fields. Thank you very much.
Thank you, John. Thank you. Now we can field some questions. We have about 5 minutes for that. Any hands going up? John, you want to unshare your screen? Yeah.
We haven't got any hands up. I think
here we have got one.
Oh, Bash.
A few. Yeah.
Yeah, Bash.
Hi, sorry. Just another quick question. Just going back to the CMT part. I'm hopefully going to start supervising a doctor who wants to CESR in rheumatology, single accredited. So I just wanted to clarify, because I think just recently, obviously things have changed to IMT, where it's dual accredited, general medicine and rheumatology. But can she still single accredit through the CESR process? And does that have to include CMT stuff too?
I think this is a question which needs to be really addressed to GMC. We don't have the knowledge for answering this particular question.
Well, sorry, Mouli, can I butt in a little bit? Because I think the CMT, the answer is very straightforward. Everybody needs CMT level medicine competency in medical specialties. You can singly accredit it as yet, but it's soon going to change, as Mr. Sandra Mouli said. Exactly when, it's difficult to say. They're planning to rewrite the curriculum, which will incorporate specialty level medical experience as well. So I think the message is to quickly get the application in before it changes.
Do you have a rough ballpark for when it's going to be phased out?
The last time I spoke to them, they said towards the end of November. They didn't specify which November.
Right. Thank you.
There was one from Mr. or Mrs. Sagdio. Yeah, Mr. Amol Sagdio. Yeah.
Yeah. My question is, when you do annual ARCP for CESR candidates in your trust, do you follow a particular format or you use the specialty format for ARCP, which is there with the specialty specific guidance?
We mirrored the specialty specific guidance exactly, because that's uniform for all specialties. Only the requirement under each category is different, especially for the domain 1. But the rest are pretty much similar, and so the format is very much based on
Right. One more question. Is there any assessor training program from GMC which we can enroll into?
It depends on the college. Like, for example, in ophthalmology, we have an applicant's training and assessor training twice or 3 times a year. But not every directorate has that, or every specialty has that. And GMC usually participates in our applicants and assessors training. I think there's one for emergency medicine, if I'm right. I'm not too sure.
Right. Okay. Thank you.
Yeah, Rakan Khalifa.
Hi, this is Rakan. So regarding emergency medicine, because the candidates and the trainees use the e-portfolio system, it's been added up recently. There is an ARCP-like form that involves how many workplace assessments happened and all of the competencies. I'm not sure if that's copied, but the problem is because all the training is done in the evidence is done in retrospect. So we have to copy the EACCS the first 2 years. On the trainees aspect, they have to do the formative followed by the summative, and they do simple things like chest pain on a ST1 level, then they have to do it on higher specialty training. We can't just squeeze our candidates and tell them, you have to do a chest pain at a very junior level, and you have to do the same one on the senior level. Then you have to do it as a formative, then you have to do it as a summative. So in terms of the way of the evidence, because we have generic forms that we can send, so it's CPD, it doesn't have to be ST1 or ST5. Would that still count bypassing all of the formative and summative, all of this hierarchy that trainees have to do over 6 years?
I think we've got Mr. Lin on, Mr. Sandramuli. Do you want him to contribute?
Yeah, I'd like to, because it's very specific for in emergency medicine.
I don't know if he's still here. Chime in.
Yeah, I'm here, Harry. Yeah, I think obviously these competencies, it's all based on obviously to get things signed up within the 5 years. And when we look at these sort of things, I wouldn't get too worried about, you've done in year 1 and need to do year 5, as long as you've got it signed off by a consultant. Now, this is the important thing, is getting the competencies done. What we find, even in our general trainees, they try to get some forms signed off by the ST3s and things like that. More so because everything is trying to squish up in 3 years, if you like, 5 years kind of evidence. The evidence must be pure and must be good, high level evidence. So it cannot be signed off, if you like, for ST3. But a couple of those. Chest trains you mentioned, I mean, if you're working in a regular ED department, you should have easily access to at least the closed chest trains, in terms of the Seldinger ones, in a year, you should be doing quite a few. Yes, open ones are a bit of a challenge, but again, if you, it depends on how big your department is, and if necessary, yes, specific kind of those things that other people have mentioned. You may have to talk with your supervisors to go to other units or where they're doing, maybe in the chest departments or whatever, and cardiothoracics to get that sorted. But that's a conversation your supervisor would need to have with your clinical director and where these things are available.
Thank you for this. My argument was about the evidence itself. So if you go into the Health Education in England website, they adopted Derby's curriculum, And if you look at their assessments, if you try to take them to your trust, it says these have to be formative and these ones have to be summative. But I can't see the point of that, because we all function at, the trainees function at the higher level. We can't ask them to go back and do it as formative. So does it make any difference if any assessment is done in a formative or summative format?
I mean, yes and no, because I think lots of things, if you're leaving it up to a chance to say, fine, you might get it done through the formative or summative. I think if you go for the higher level of competencies, there's always a chance. I mean, emergency medicine, we have been doing this for a few years. I mean, we in New Cross, it's new for us as well. But I would suspect you try to get those sort of competencies on a higher level, that will always be more sure that you'll get your thing through. You don't want to come back basically saying that, oh, you haven't done this through a formative process or summative process, then that needs to be done.
Yeah, I think, Chairman, we'll probably might need to move on, because I think this seems to be a very ED specific issue. So maybe we can address the answer a bit later. Is that
where are you working currently, Ratan?
I work at City Hospital.
City Hospital. Okay, have a chat with Bish. Bish is out there in is he Sunderland City?
Sure.
He'll be able to guide you.
Both cross sites.
Yeah.
Okay. Thank you.
I want to introduce the next speaker.
So the next speaker is Mr. Bitar, who is one of our success stories in New Cross Hospital. He's cleared his CESR very recently, about a year or so ago, and is now a substantive consultant in our own trust. So, Mr. Bitar, over to you.
Hi, everyone. I think there are lots of people. It's more people than what I thought would be. So my name is Khaldun Bitar. And as Dr. Butch said, I've born and bred in Royal Wolverhampton Hospital in a way, actually. And I'm very proud to say that, yeah, I have a successful CESR story to share with you. Now, I don't know if you can see the presentation. Can you see it?
Yes.
Yeah?
Yeah.
Because it's taking me out the meeting, so I'm not seeing anyone. I'm just looking at the presentation at the moment. So yeah, so you can see this, the first slide. So yeah, it's a short talk that I'm going to talk to you for 10 minutes about my experience as a CESR candidate in a very different times actually than the ones that we are in at the moment. So it will be 10 minutes and then we can share, answer any questions if there are any. So just to start with, I think we all know by after Dr. Chandramooli's talk, we know a lot about CESR, and to me there are two categories of CESR candidates: those who are junior and couldn't get an ST3 in their relevant specialty, and they end up going through the CESR route, or the ones that are senior overseas qualified doctors who can't be. Sorry, I can hear lots of interference actually. Can everyone mute their microphones for a few minutes, please? Yeah. Yeah, so I meet the first. I'm in the first group. So I qualified overseas and did my basic surgical training, CT1, CT2, and I tried for an ST3 number, but I could not get through. And at some point in my training, around third year, I realized that I'm being down-marked for an ST3 job in trauma and orthopedics, and I decided to go through the CESR, then called Article 14, as we all know it then. So I was given a clinical fellow job in 2010 in Royal Wolverhampton Hospital in trauma and orthopedics, and halfway through my middle grade training, I realized that I am not going to get a training number. And I decided to go through the other route. So I prepared for the exam, the FRCS exam, and decided to go through fellowship and completed my CESR application, submitted my CESR application in 2017 to cover the period of 6 years. Now, I'm sorry if there is some discrepancy between what I'm talking about and what Dr. Sandra Mooley talked about, but at the time I applied, it was 6 years. So I'm aware of some changes now, but please, this is just my experience at the time. So I got the CESR in July 2018. Now, my experience is as expected, really, and as what Dr. Sandra Mooley suggested. I started on my own, basically, at times where there were no guidance, no such talks or meetings or groups. So people knew it as Article 14. I started prospectively gathering all the evidence required. As you know, I used to consult with my deanery trainee colleagues, really, that what's required. What do you do in an ARCP? How many procedure-based assessments do you need? How many CBDs? What's this? Show me that. ISCP is the equivalent of e-portfolio for other specialties, so I enrolled in that. And I kept a portfolio initially meant to get me an ST3 job, but then carried on. And actually, at some point, I stopped paying the fee. I stopped paying the £250 a year. I thought, if no one is looking at that, I'm going to do my own portfolio. So I kept a paper portfolio. I used to print them off the internet, and get them signed as I go along. So I do an operation, and I get my supervisor to sign me off. And at some point, the ISCP stopped allowing this. So they took those templates off, and I managed to source some from a trainee who had them on a USB. So I kept doing that until such time that they start changing all this. So basically, the bottom line, what I'm trying to say is that I persisted in prospectively gathering the evidence. And I think that's the most important aspect of a CESR application. I used to print the old RITA form, or the ARCP form, that trainees used to have in their ARCP, and I used to get my clinical supervisor to sign me off as well. Until such time where appraisals were introduced by the GMC, and they were mandatory for every doctor. So I converted to that. I had lots of support from my department, but it was all informal, not under the CESR or Article 14 umbrella. But overall, I think my experience was fair, or actually the CESR application experience was fair. It actually, overall, it was quite labor intensive, and at times it was quite stressful. I had, you tend to lose hope sometimes, but looking back at things, I think it made me a better person, because you learn to be disciplined with all the evidence that you gather. I remember actually in my when they gave me the decision, they actually commented that it was a strong application, and they were referring to item page number 1700. So there were quite a lot of evidence involved in this, and in my application at least. Now, I faced lots of challenges, which I don't think is surprising, but as Mubarak said, it is a self-driven process. So
Aldun, I'm sorry. Are you trying to move your slides, or because we haven't? I think the slides are not moving.
Oh no, I've moved. I'm almost done. Sorry,
it's not rolling.
Okay, so which slide can you see at the moment? Because
my experience as CESR candidate.
Oh, all right. Okay, 1 second. Let me see what's. Can you see that?
No.
We can't see anything now. Oh yes, it's back.
Yeah.
Can you see that?
We are still on the same slide. My experience as a CESR candidate.
Okay. And now?
No, same.
No, Khaldun.
Okay, sorry, let me just see, because
yeah, it's moved now.
It's moved. So you can see challenges now, yeah? It's probably just lagging behind a little bit, I think.
Quite a bit, I think.
Yeah. So are we on challenges now, yeah?
Yes.
Okay. So yeah, so keeping myself self-motivated, because there's no one looking up over my shoulder saying that you have to do this. So it was all me, and I agree with Mubarak. At times I actually just took a back seat and realized that there was 6 months gone by and I have not even done one WBA. So it was quite difficult. There was no panel, no ARCP panel to look forward to be scared of at the end of the 6 months or end of the year. I didn't have the luxury of what Dr. Butch and Dr. Sandramouli is providing now, and talks and what to expect and how to gather evidence on. No one to actually reach out to, at least not as available as now. So it was quite difficult. The other challenge was the logbook. As a surgical trainee, procedures are very important, and just for non-surgical specialties, index procedures are certain procedures that we have to do, at least in trauma and orthopedics, that we have to achieve certain numbers of each, and that was difficult as well. I heard lots of horror stories from failed applicants who go to meetings, who go to courses, and it's lots of demotivating stories, but I did not let that stray me away from my goal. And being in obviously, I mean, I think the last point of being dean, I put that deanery trainees down because I think it will be an ongoing challenge, because trainees always get the basically the easy run, and that was difficult, at least in my days, when a trainee would need to do a foot and ankle post that has to be addressed, and that was a challenge. So that impacted slightly on my trauma numbers, for example, which I had to address in my second fellowship when I did. So that delayed my application. But again, I think times are different now, and we have lots of positive things to talk about. And I think most of the challenges I faced I could say that actually they're non-existent in a way if we actually get the right candidate. So we have, as has been mentioned this afternoon in Wolverhampton, we have a CESR overseeing panel. Clinical fellowship program where we basically have clinical fellows at junior and senior levels, and we filter them through to basically get them where they want to be. And more recently, CESR education supervisor roles have been given, and I have taken one of these roles to look after orthopedics or trainees or surgical, but at the moment we've got enough orthopedic trainees who are interested in applying for CESR. So another thing that I was asked to talk about is what kind of CESR candidate expect, at least in surgical specialties. So I think someone like me, I mean, back in the days, if you tell me that I have an educational supervisor for CESR, I would have no expectation from that person because I was doing it alone. But now, those kind of roles and supervision, which is great. And similarly, they could expect everything, and we can't provide everything. Most CESR candidates, including myself, have not been in a deanery training post as a registrar, and the process of basically having someone over watching them and ensuring that they have all this process structured feedback is something that they may not be used to. So They do need active guidance and support. I think as education supervisor, I would like to think that I'm an advocate on their behalf to help them achieve what they have to achieve. And for the last 2 months, or actually, yeah, for the last 2 months now, since I was assigned the role of education supervisor, the way I started is that I reached out to all the middle grade non-trainees through my secretary. I sent them an email saying that I've been given this role. If anyone is interested, please let me know. And shock horror, everyone is interested, and obviously that's a problem. But we have to filter through this. So another email went through. That's great. Let me have your CV and your provisional CESR application date and everything you've done, audits, WBAs, and everything, all the courses, everything that you've got evidence-wise. And obviously, as you can imagine, only 4 people replied. So I think it is important to choose the right candidate. Yes, we don't have any authority to basically stop their training or hold them back. We all know that. But I think to start with, the interested ones, the genuinely interested ones, I have sat with. We have done individual meetings, shared expectations. So I've listened to their expectations and I've let them know mine. So it is important that, it's not something that I can shove down their necks and say, you have to do the CESR. That's the rule number 1. They have to show me as an education supervisor that they are keen, that they're going through. So I need to see so I've signed, so on the ISCP, everyone have a clinical supervisor and I will be named education supervisor. So I'll go through the learning agreement, sign it off. And we said that we need 1 audit in 6 months, we need one presentation in a year, and we need to see certain amount of WBA. This is all tailored to each individual. And that's where we are now, or that's where I am now at least. It is, I think I talked about most of this. Sorry, are the slides moving along with me, or are we still lagging behind?
Yes, they have been moving now.
They are moving.
So are we on how to deliver as an ES in a surgical specialty now?
Yes.
Okay. So so that's what I've been doing. I've been getting involved in the ISCP learning agreement. That's all electronically signed off. If a placement is 6 months, we're doing an introductory learning agreement and a final signing off agreement. I haven't reached the latter one yet. I have identified that there are different CESR candidates can be on a spectrum. So there will be someone who is 3-4 years away from their CESR application, and there will be someone who actually is looking into applying in 6 months. So each one of these people will have different needs, obviously. And while I am passionate about CESR because I know the struggle, so I have taken it on me to give guidance to those who are not there yet or not formally there yet. But in the trauma and orthopedic department in Wolverhampton, we have actually 5 people who are, I think at least, would go through the CESR route genuinely. Other thing is in orthopedics, we have lots of subspecialties that needs to be met and needs to be, this for me, this is the challenge, but our department is quite supportive, and I have been liaising with clinical supervisor and our clinical director, and no one is opposing the support for CESR candidates. And I think just my last point is like, can we? It is a difficult ask, but if we want to make this work, we really need to prioritize trainees based on their needs, not whether they're deanery sponsored or trust sponsored. Thank you very much.
Thanks, Khaldun, for that excellent talk. I think we have 3 hands up. Bash, Dr. Bash. Shall we start with that first question from Dr. Bash?
Not this time for me. Thank you, though. That was really helpful.
Please lower your hand in that case.
Sorry.
Nelam Abesekra or Abesekra Nelam, sorry. Hello? Abesekra? No? Okay.
I think that's me, is it? I'm struggling to hear. Ling, yeah. 2 quick questions. One is that I have a trainee who came from India. I think it may have been covered, and is now doing a 3 years, has already finished 3 years. Wants CESR just in gym. I'm a bit late in my development. I'm his ES, but I am a gym consultant. So can I sign off anything retrospectively for what would have been his core training in India? That's my first question. I've got another.
By direct observation, so I don't think you can sign unless they are friends.
Okay, and then the second thing is you alluded to things disappearing off the menu, but you didn't say that this option, as even though he's doing endocrine clinics and he's done a lot of endocrine, he said he only wants the CESR in gym, so that's not going anywhere. That's going to be an option, is it?
I didn't get that question.
He wants to do a CESR just in general internal medicine, but no speciality. Is that okay?
Well, you need to check on the list, GMC. I think it is possible, but I'm no expert on that. The list is very big. It's 65 specialties, so you need to check against that.
Yeah. Okay.
Okay. Moving to Pulikal Ravindranath.
Thank you. Just a question to the Dr. Bita. How many candidates can you keep yourself under as an educational supervisor for, and how much work does it involve? Because we got a number of clinical fellows in our trust.
Yeah. So we actually, this is probably this has been discussed with Dr. Sandramuli and Dr. Butch, and because these jobs are on an ad hoc basis. I mean, we said that something like 5 to 6 trainees is what we agreed. Because it involves basically touch basing with them if there are any problems, and 2 formal meetings a year with each. So I think that's quite a fair number. So far, I'm not overwhelmed, but that's what I'm capping it at 6.
Thank you.
Thank you, Markham Pratap.
Yeah, very nice presentations.
Yeah, thank you.
I've got one doubt, general doubt in regards to the CESR candidates.
Yeah.
Is there a separate budget for secondment attachment? The budget comes through the local directorate, or is there a separate funding from the local hospital?
I think it is a trust arrangement, and only recently our trust has agreed to support out of program for 3 months.
Sorry, it was breaking. If you don't mind, repeat it, please.
Yeah, it's a very trust-based approach. It's very local, it's a local arrangement, and our trust has recently approved 3 months secondment as part of the program, so which means the directorate will be budgeted for it. And I think John Mohammed did one recently, earlier in the year, for transplant medicine under that scheme.
Thank you.
Right. I'm conscious of time, so one last question from Shahid Gilani.
Yes, are you getting my voice? Hello.
Hello, yeah.
I just want to know, sorry for naive actually, because I'm very new to this. How much time it takes prospectively, how many years it takes, this is the process and the current situation, and it's going to change?
Well, the time scale it depends very much on the specialty and the experience of the candidate. It could be anything from 2 years, I would have thought, to 6, 8 years. But it very much depends on the specialty and what prior experience the candidate has.
Right. So how retrospectively this experience can be shown when there is it's only clinics done and no law books have been made and there is no sign off. So can that be rectified retrospectively?
You can still show it because it's experience gained, but evidence has to be there. So that means you need to top it up and show that as current and maintained, as I highlighted in my talk.
Right. Okay. Thank you.
Okay. Right. I think we'll move on to the...
Hello. Hi, I'm Sukesh here. I have recently joined Trust from about 6 months ago, and I've done my CESR recently. Just would like to add, then even after submitting the application, it may take at least 6 months. Means when I submitted my application, it took me 9 months, even after submitting the application. So be prepared for that if the people are thinking about it. Thank you.
Thank you. Thanks for the comment. Now, we'll move on to the last speaker, and thanks, Khaldun, for your very useful talk. We have Dr. Butch now, who is our consultant endocrinologist and diabetes specialist. He is the doyen or guru of our clinical program and CESR program as well. He's going to tell us about his experience as the next talk. Thanks, Sarit. Harit?
Yeah, not surprisingly, it's me who is struggling now.
Do you need help, Harit? You want to send it across to me and I can show?
Well, I got it working when I was trialing it, but I'm just now 2 minutes ago, and I think you might have seen it on the screen.
On the first slide, yeah. You want to send to Anjali? She seems to be our local expert.
Yeah, Harit, we can see your slide now.
Yeah, we can see it, Harit.
So you need to share the screen.
Yeah. Okay. Just 1 second. I think I know where I was going wrong.
While we are doing this, can I remind you to fill your feedback form if there is a link appearing somewhere in your chat box, please. Otherwise, we'll have to send it to you separately for you to complete it before you can claim your CPD. Thanks, Harit.
You can see it now?
Yeah.
Okay. So what I'm going to talk about is a bit more local compared to what has been discussed thus far. Just to give you an idea of what can potentially be done across different trusts if you have enough number of doctors who want to go through CESR program. I'll go through the background of how we formed the program, the structure and the roles of the CESR program, what have been the benefits and the risks potentially so far, and what progress we have made in terms of numbers. So it all started back actually in 2016 when the trust recognized that there were so many junior doctor vacancies, and it imposed a lot of clinical and financial risk to the trust that we developed a program of clinical fellowship jointly with the University of Wolverhampton. In addition to mitigating the risk imposed by the junior doctor vacancy, the other perceived benefit of this was at the same time we were undergoing several areas of expansion of services, including the 7-day working, enhanced out of cover, and the specialty service expansion. And with these twin aims, this program was launched back in 2016. But right from the outset, it was decided that for the program to be successful, it has to be based on a strong emphasis on training, education, and career progression of the doctors who are recruited from within the country or from abroad. So in addition to all the standard and the fundamental training support that we all now recognize as mandatory, we also added on a fully funded master's program at University of Wolverhampton, and we ensured that those doctors who are working in a more generic field, they should get exposure to the specialty of their choice for at least 20% of the 20% of the week, which would be mainly applicable to medical specialties, as there is so much of general medicine involved. So what happened over the next, are you seeing the change in slide?
Yes, yes.
Okay. So this is the total number of clinical fellows. If you look at the line at the bottom, the number of clinical fellows has actually risen over the last 4 years, almost threefold in the trust. And that is an interesting point because at the same time, the junior doctor vacancies have gone down considerably between 2016 and 2020. And therefore, it's the second objective which is mainly driving the recruitment for clinical fellows, which is expansion and enhancement of services. And that is clearly reflected in the difference in the distribution between the different levels of clinical fellows. And these percentages are not absolutely accurate. They're slightly, well, they're almost accurate, but they're not, it's very difficult to get updated numbers. But you can see how there is a gradual shift from clinical fellow positions to senior and advanced clinical fellows. And what that did was it brought up, it made the trust have a lot of doctors who are in the lower part of this table. So those who are clinical fellows, they often quite rightly enter the training program, or some of them acquire certain skills, and if they're from abroad, as most of them are, they go back to their country. But it's the more senior doctors who often have several constraints to pursuing conventional training. And as the number of these doctors grew, that was actually the main driver for developing the CESR program back in 2018, because we were left with 30, 40, 50 doctors who were quite experienced, but didn't have a clear pathway to career progression. So since it has been established, now the CESR team currently looks like this. So in addition to myself, there are now, as Mr. Bitter indicated, there are 6 educational supervisors. All of them have either been CESR doctors themselves, or they are CESR assessors for their colleges, or they have some additional CESR experience. So they're all CESR. We have an SAS tutor who has got CESR experience. We now have a clinical fellow program education lead who joins this structure. And most importantly, we have 2 representatives of the CESR doctor group. One of them is Jan Mohammed, who has done the earlier presentation, and we have one from orthopedics. So both these doctors, they help us in the CESR support process. So one of the issues which is often brought up is that CESR is mainly driven by the applicant and supported by the directorate. So what are the roles for the trust to fulfill in this whole process? And I think if you sit down and think about it, there are several ways in which the trust can actually help this process. Now, I've listed these here, and I'll expand on 2 or 3 of them. So the first thing we did actually was to find out who are the doctors who are committed to pursuing CESR, because there is no formal entry criterion. Anybody who says, I'm going to do CESR, I'm thinking of doing CESR, I'm dreaming of doing CESR, we can't just provide intensive support for all the doctors. So we defined certain criteria to, as Mr. Bitter rightly described, as his initial mail brought up 15 applicants, and when he refined the selection criteria, only 4 of them fed back to him. So the criteria we use are that they should have a definite plan to pursue CESR and in all probability put in their application within 3 years. They should have satisfactory performance at different levels of their assessment thus far. They should be maintaining a log of their activities, and they should have cleared their specialty examination. Now, in some of the specialties, these examinations come at the end of the process, so it cannot be that we can't use the same criterion for all of them, but for a majority of these specialties, examination clearance becomes a signal that this doctor is now ready to be fully supported for CESR. The next process was to appoint CESR experienced supervisors, which I described, and they have a 6 monthly meeting with the doctors, draw PDP, and most importantly, they help in discussing or determining the time for final application. The ARCP process is the other form of assessment that takes place. I think this has been mentioned 2 or 3 times, and there's been some discussion on this. It's largely a formative assessment. It cannot be summative under these circumstances for CESR doctors. The panel consists of 2 specialist supervisors and 1 directorate representative. They are assessed against CESR guidance. And most importantly, the document which is produced, which is full of recommendations for the next year, it forms as an important component of their CESR application, because the CESR assessors are quite keen to see whether the CESR applicant is periodically being assessed or not. So the other important role that the trust-wide program has is to work closely with the directorate. So we have to ensure that there is appropriate clinical supervision, which helps us to achieve the PDP. The doctor needs to be provided with opportunity they should have the exposure to all aspects of curriculum, because the width of the curriculum is far more important in CESR than the depth of curriculum in each and every component of it. I mean, it's difficult to exclude the depth, but the width is absolutely essential. So they should have exposure to all aspects of the curriculum, and that's where we need the help of the directorate. As I would show in my next slide, we train these doctors to develop additional roles, but it's up to the directorate to provide the opportunities for them to manifest this training. So if they are trained to be clinical supervisors, they should be given a candidate to be supervised. But I think by far, the most important directorate issue is that they should have a supportive culture within the directorate. It's not just one educational supervisor who can achieve, or a clinical supervisor who can achieve much. It needs the entire team to be supporting the doctors. And in simple things like signing off WPBAs without having to send multiple reminders, these sort of things go a long way in making the CESR doctor feel that he's being fully supported within the directorate. And I think this is the kind of dialogue we often have with individual directorates. Some additional study leave funding can also be mustered for the more determined candidates. So this is what I alluded to earlier. We help in training these clinical the CESR doctors to develop their non-clinical domains. As a supervisor, as an appraiser, we have run management courses to help them with management skills, because that's another requirement of the CESR application. The master's program is available to them just like for any other clinical fellow. And anything that is going on in the trust, we often think of the CESR doctors. So for example, so we have widespread enhanced support services for clinical fellows, and we invite the CESR doctors to deliver these. Now that becomes a very important message for the new clinical fellow, but also becomes an important piece of evidence for the CESR doctor. We ask them to come for interviews, so that becomes another piece of evidence. Any of the governance roles that are going, so they are often joint investigators for RCA, which is again of great importance in their application. And likewise, all these other activities, the CESR doctors participate. It proves quite helpful for the trust and for the CESR doctors, so it's mutually beneficial process, and it's just a question of just thinking about seeking their contribution. So peer group activities have been described already, and Dr. Mubarak runs this along with Mr. Matthias from orthopedics. We have also arranged GMC workshops. This has been mentioned before. Secondment has been discussed. So I think a lot of this has already been covered. There is a process for mentorship and pastoral support. And we often also help the directorates to develop a CESR post to start with. So rather than somebody coming into the trust and then thinking of CESR as a subsequent measure of career progression, they could probably join the trust for doing CESR. The post is advertised and described right at the outset. So if we look back over our last 2 years, I've just given only 3 points each, although there can be a few others in both categories. What are the benefits and what are the risks of the program thus far? And I think we have been able to produce brilliant homegrown consultants, one of whom has already spoken to you and the other may speak to you at the next similar meeting. So I think that's one big plus point, that the trust has always looked upon favorably at this process, and it meets that requirement quite nicely. To have a CESR doctor within the team, so we have one in diabetes, and it's a great, that person is a great asset to the directorate because it's obviously by definition is an experienced doctor, and in addition to that, there is a length of service that they give to the directorate in comparison to trainees who would come for a year or so. CESR doctors are within the team for 3-4 years. This in turn leads to recruitment and reputational benefits for the trust. In terms of the potential risk, one of the issues which is often brought up is a bit contradictory to what Mr. Bitter was saying. Do we become too obsessed with the CESR doctors so that the specialist trainees no longer get the attention that they should for meeting their requirements? And I think in our experience so far, it's generally not been the case. In medicine, it is never the case. In surgery, I think with appropriate planning and discussion, I don't think this becomes a serious issue, or it hasn't become one for us so far. But theoretically, this has been raised once or twice. More commonly, what does tend to happen, and I think as Mr. Sandermuli might support this, is that the directorate has different service needs. While the CESR doctor wants to meet his or her own curriculum requirements, and these two don't always go in parallel. But again, these are the sort of issues which have to be dealt with either proactively beforehand, considered at the time of appointment, or as you go along, there has to be a dialogue between the supervisor and the clinical director to resolve these issues. The last one has been a bit of a surprise because we did not expect this to be the case. Because of a lot of effort made on CESR, a lot of clinical fellows find CESR as an attractive option when actually the training is a much better option for them. But because CESR looks attractive and appears easy, quite often people are tempted to go for the CESR option. And we spend a lot of time in trying to discourage them, explaining to them that it is not quite easy and it's probably not appropriate. So I think as it has been mentioned previously, the right person has to follow the right path. And we have convinced a lot of the clinical fellows in pursuing training option. So that's all I have to say. I'll end with this numbers. So we have, at the moment, we've got 30 doctors in the trust who are committed to CESR. We got another maybe 20, 25 who are, as I said, thinking about it, waiting to see what happens to the training applications, but 30 of them who are well on their way to CESR. Over the past 2 years, we have had 10 successful applications, and Mr. Bitter is one of them. 2 of them have had their applications sent back for revision, and the revised applications have been sent back to the GMC, and we expect successful outcome. And we have another 5 or 6 doctors whose applications are imminent. So that's where we stand. I think that's a reasonably good number, considering we've only been going for 2 years. So I think the last thing I would say is it's certainly to have a good CESR doctor in a directorate, or a good number of CESR doctors in the trust, is quite a win-win situation for the trust and for the doctor, as long as they are well supported. Thank you.
Right. Dr. Butch, there are some questions in the chat, so I'll quickly go through them before you ask those who have raised their hands. So the first question is, does the trust give appropriate length of employment to the requirement of that particular clinical fellow who is doing his CESR?
Yes, is the quick answer. If they are appointed not originally for CESR, then there has to be a reflection within the directorate whether they'll be able to support CESR or not. But we haven't had one example where person is committed to doing CESR and has not been given the length of employment.
Right. The next question is, do you have a list of trusts around Midlands who support CESR?
I have only one. No, unfortunately, no. I wouldn't know what is happening in other trusts.
Right. And the last question in the chat is from Menik Upatissa. Is there a possibility to get advice for SAS doctors from other trusts to get advice on their CESR application?
So I think I have to apologize. I haven't mentioned SAS doctors even once, but it's only because in our trust, the majority of the applications or the committed CESR doctors are clinical fellows, but we have 4 or 5 SAS doctors who are also in the process. So yes, SAS doctors are more than welcome to seek advice from us. There is absolutely no problem. Our SAS tutor is very well informed about trust. I don't know whether he's in the audience or not. So either you can ask his advice or mine or anybody else's, Mr. Sandramuli. You're more than welcome. Was that the question?
Harriet, I'm in the audience, and I'm welcome if anybody want advice from us. Yeah. I'm most welcome to give the advice here.
There are a couple of hands up. One is Abhay Sekra Nelam, or whoever is sitting with him. Shahid Gilani. No. Angela Nandi.
Hi, I'm Shahid Gilani.
Thank you. I just wanted to add that if we have to contact your trust or yourselves for some advice, how would we go about doing that? Is it to yourself or, I mean, for a physician trainee?
Sorry, Muli, can I answer this one? Because the easiest is send me an email. I think if you want, you should have my email address from the list, or I'm not sure how I can convey my email address to you, but you're more than welcome to seek any advice anytime.
Shahid Gilani.
Oh yeah, I missed your call before. I just very quick question. Technically, what is the difference between clinical fellow and SAS doctor?
Well, SAS doctors are more, let's say, they're more experienced senior doctors who are on national contracts, while clinical fellows are on trust contracts, and they are, as a rule, initially, the clinical fellows are probably less experienced, but as they go along, they acquire the same level of experience as the SAS doctors. Is the broad difference, but then there are several other differences.
So do you recommend SAS doctors to go for CESR or just continue as a national contract? because they are not much supported and there is no leave, there is no funding. They're always working. They are working at least at a consultant level. They're doing the same job as consultants are doing at the moment. Our hospitals are run by SAS doctors. I know many associate specialists.
Well, I think this is an individual choice, whether you want to carry on or you want to go for CESR. I don't know, Mohammed, do you want to answer this?
Thanks, Harry. I mean, I quite agree, Harry. This is a absolute individual decision. It depends what you're doing. If you are happy what you're doing, if you're satisfied, if you continue education, as your professional development is fine, if you want to continue this particular job, that's perfectly fine. But if you want to move on to the next step, and if you think that, as all these talks shows you, that if you're capable and if you have got the ability and capability, I must say that you should go for it. But the whole purpose of this talk was, first, are you ready for these things? And this is your decision. You need to ask yourself this question. If you are, then helps is around there to help you out.
I can add to that. In my department, 2 SAS doctors who are highly motivated and committed were switched over to CESR fellows. We created 2 posts from the same SAS pot of money and made them CESR fellows to steer them, and they're doing extremely well. They've done it for 2 years now, and they are likely to apply in the next 12 months or so for a CESR application. So it is possible, provided, like I said earlier, your departmental colleagues are happy to support it. That culture has to be there, not an empty promise. It's a very, big discussion that you need to have with your colleagues before you can embark on committed people to be promoted in that direction.
I think, can I just add on, and you're quite right. It's part of the fact of making sure that you have the right person, and the right person in terms of making sure that they're doing, it's just not their daily job, that they have been engaging in sort of their CPDs in terms of doing exams and things like that. It shows that they're committed. There's no point just saying that, yes, I want to do it, but if there's no push towards getting their WBA, BAs and the things, that's going to be an absolute failure, and he will not progress in his CESR application. Right
person and the right team. I think both have to click.
And your commitment, so important.
Absolutely. I think I can see a couple more hands there. Sami Eldeaf.
Yes, hi. Thank you very much for all the informative presentation. So I'm a consultant obstetrician and gynecologist at Warwick Hospital, and I have helped a few candidates to get their CESR, and they have moved on now to get their consultant jobs, thankfully. I just had one question which I was a bit confused about from your presentations. You did say you had local ARCPs. Do you mean appraisals? Because we don't have, obviously, local ARCPs within our trust for specialty doctors or trust doctors.
Khalid, do you want to come?
Well, I think when we say ARCP, it's to make it aligned to the ARCP that the trainees have, but clearly the ARCP that the trainees have become a summative assessment, because the trainee can be stopped from moving from, say, ST5 to ST6. Now, that doesn't happen in these ARCPs. This is more in a more formative review, where each year the evidence they have collected is matched against the CESR specific guidance, not just by their supervisor, but the supervisor, another supervisor, and the directorate representative. So whatever the gaps there are, that helps them to form further plans. The directorate representative then finds the ways to achieve the gap, to fill the gaps that exist. So it becomes more of a formative assessment, and I think I can probably understand the slight objection you would have in calling it ARCP, because it isn't a summative assessment, but it just is. This is why we call it annual review of CESR progression.
So is an appraisal adequate then, which will cover all of this?
The appraisal is completely different. The appraisal is more for minimum requirement of being practicing as a doctor. I think the trust appraisals that they have, they are not that heavy on the career progression that you could probably make it more analogous to educational supervision meetings rather than appraisal.
Which is what I was doing with that candidate, and he's managed to successfully complete
Correct.
it.
Yes. So I think the AHCP is just a value-added educational supervision meeting when there are other people other than just the supervisor to give a different angle to the evidence.
It's very CESR specific.
Yeah, so I mean, as a result of this, I have like at least 3 other candidates now who are sort of hounding me to help them out. So I was just, I'm glad there is this platform now. So I was wondering if I could be able to sort of divert them to Khaldoon or to Jan Mohammed for other sort of extracurricular advice on how to complete their paperwork.
Can I just jump in there just briefly with regards to at least emergency medicine? Most of my people who come in either through your clinical fellowship program or the CESR program, it's always we get them through our portfolio. So 2 things. Number one, the portfolio will help them to move whichever direction they want. So the junior people, if they are good enough and they go into national training, that will help them in showing the evidence of the work that they've done during the time they're with us. Plus also, if they do decide, if we do decide that they are good enough to be switched over to the CESR program, that is still the evidence that they would need to submit for the CESR application as well. I don't see why we can't, and I think we are using these ARCP outputs as part of their annual appraisal for non-training doctors as well. Does that make sense?
Yes, it does.
Yeah, I think this help. I'm sure Mr. Pitar and Jan Mohammed will be happy to answer your queries. We also got one in Obs and Gynae who was with us earlier, but I think she has left. So we'll certainly be able to help you. If that's what you want.
Thank you very much.
Upatisa.
Thank you. It's been helpful. I'm afraid I have to leave now. Thank you.
Okay. I think we have Sukesh Mota.
Yeah. I just wanted to first I would like to congratulate that Wolverhampton Trust is doing so good for the CESR people, and just I would like to one comment. It is definitely helpful if the trust is helping, or if you're in a right trust who is helping for CESR application. But I think it is the commitment of the candidate itself, because I have moved around to many places and then I have done my CESR application by my whole, and it was approved in first application itself. So I think there are ways of doing it, and GMC guidance is helpful, and then if you pursue it is doable. It is not necessary that the trust or supervisor has to help you out. You can work around your ways.
True. It depends very much on the self-motivation. I agree. Any other hand up? Yeah, Ansari Ziauddin.
Yeah, hi. You mentioned that you are supervising the CESR candidates. Are you job planned for these things, or are you doing it on your extra time, SPA time, as a consultant?
It started as a self-initiated, aspect only, and because of late I've become a CESR education supervisor for the trust. I do get remuneration now on the back of it, but I think once you started, things start to fall in place in a good, appreciative trust, such as Wolverhampton.
Yeah, okay. I am supervising 3 registrar grade doctors. Out of 3, 2 of them are willing to pursue CESR. So do you think I can ask my trust that it has to be remunerated?
I think it's very much a local issue, I'm afraid.
Okay, thank you.
Thank you. I think I can't see any other hand going up other than the ones who put it up, but I think forgot to take their hands off. We have come to the conclusion of this program. I think it's been well attended, and the audience was really good. Fantastic, in fact, lots of good questions. I suppose, Rupan.
Sorry, it's me again. I still don't have the chat function on my Teams, and I still don't know how to get the link for the feedback.
Well, as I said, if it is not, then I'll have to ask the management to send separately the feedback form, because I don't think many of us have got the chat function, including myself.
No, so the link for the feedback forms has not yet been posted on the chat. I tried looking for it as well.
Okay.
So I think it will just have to be emailed to all of us.
Yeah, I think we'll ensure that that's done, and your CPD points will be with you.
Lovely, thank you.
I think we've got one more, Cherry and George.
Yes.
Oh, it might be a mistaken hand.
I think it was a mistake, yeah.
Right. Okay, Harit, anything, last word?
No, that's absolutely fine. Thank you, everybody, is the only thing I have to say.
Thank you. Thanks for the speakers, audience, and everybody. It's been a good meeting, I think. Thank you very much. We'll send the link for the CPD.
Thank you, everyone. Appreciate it. Good meeting.
Thank you. Bye-bye.